Great. Thank you very much, Dr. Stewart. Okay, so now we're open to questions. This is meant to be an inclusive session, so if you have a question, would like to go to a microphone, please do so. We do ask that you go to the microphone so that we can record the question and be able to respond to it. Great. Dr. Shilsky.
Rich Shilsky from ASCO. So lots of interesting issues already raised. I wanted to maybe come back to a word that Hedda used in her remarks, the word being integration, and ask the panel members for your thoughts about sort of when and how this integration might occur. So, just thinking off the top of my head, consider the following scenario. A patient presents to their primary care physician with a new cough and weight loss, and the doctor orders a imaging study, and at the same time orders a blood test for circulating tumor DNA. What we've heard is that some of the imaging studies are highly sensitive but lack some specificity. And some of the circulating tumor DNA tests have high specificity but low sensitivity. And are we headed toward a time when, we can begin to combine technologies to get sort of an optimal diagnostic assessment? And if so, where does that integration occur? And how do we prepare the workforce for that integrated diagnostic approach? Dr. Cohen raised that issue as well. So I'll sit down and let you guys talk.
Let me try to answer your questions first. So you're jumping to 5 years from now. Absolutely. No, I did teach you right. Rich, there are a few pilot studies in a different university, and I would like to hear from the audience. We have a pilot study as well. The biggest problem is manpower. So we decided to invest in this. So therefore, bone is the easiest example because in musculoskeletal, because of pathology already heavily depends on imaging findings. So now they do integrated report. But that means that radiology is read, pathology is read, and then the two of them either talk on the phone or in the multidisciplinary and issue a report. We're going to do the same with prostate, just because we have a very large volume. But it really requires people, either two of them working together, or a person that can integrate and communicate. We do hope that in the future we'll have analytics, data analytics that are going to help you. We right now, something that's so mundane and we often don't talk about, we don't have quantitative radiology or pathology. We don't have not structure report, but synoptic reporting where you can really enter data for the data analytics. So we don't really have a base at present. There are going to be a few universities. ASCO is doing AACR, as you know, Genie project, realize what's missing, history. Wow, what a revolution. So we don't have, and our records, basically you have to go manually and edit. So we are now hiring scripters that are going to do that because there's no way that you can do that otherwise retrospectively. So there are, in integrated diagnostics is no question our future. It's not a year from now. I think I'm looking at Jim and there are some others. It's at least 5 years ahead to really disseminate and really, because first you have to develop, then you have to validate, and then you have to disseminate. And it will take us a while, but I actually think it's the best part of diagnostics.
Dr. Cohen, did you want to respond also?
So let me answer that in a slightly different way. And I guess I'll go back to Dr. Brawley's example of the pap smear. Ultimately, I think our society's going to have to decide where it wants to invest its resources. And there's a lot of sophisticated stuff coming down the road. But I spend a lot of my time looking at Pap smears. And the reality is most women that develop invasive cervical cancer have not been screened in any reasonable time frame or ever been screened. And so the question is, do you want to figure out mechanisms to enhance screening of those women, or doing the best that you can for women who have already come into the system? And given limited healthcare dollars, I think that's an important issue. That said, I agree that obviously, this integration is occurring. But I would caution that, a place where the Heady works is a pretty unique environment. So if you're in a community hospital of a couple hundred beds, where you may have 3-4 pathologists and maybe, 10 radiologists, that type of work effort may not be feasible.
So why don't we hear from someone in the community on that issue of integration? Would someone like to comment?
I must admit that it is very forward-seeing, and we can see the time when a laboratory and a radiologic diagnostic are done simultaneously. I guess I hate to be such the naysayer, or not a naysayer, but a commenter. I think I look at our current need for integrated reports, and specifically as we see flow and cytogenetics or genomic reports all coming back separately, often from separate labs in different formats that get shuffled in different media tabs or scanned reports. And I must admit, I think from a community delivery system, integrating those reports into a common diagnostic portfolio is really key, and something that would seem that our current technologies ought to help us solve.
Dr. Brawley?
And I need to just give a credit to David Klimstra, who is a chair of our pathology. That's exactly his number one priority. You know what's his biggest problem? That different reports are in different systems. So they are putting a separate server in order to integrate. But that's exactly his number one priority.
Let's go to Dr. Brawley first, and then we'll go back down.
Very briefly, because this hasn't really been mentioned, but we have to consider it, I think. In the past, most X-ray imaging has been anatomic, but some of our nuclear medicine imaging is more and more becoming imaging that's both anatomic as well as physiologic. And that's actually a new frontier as well. I'm thinking of PET scanning, I'm thinking of molecular breast imaging and other things. I just wanted to throw that out on the table for consideration.
Thanks. Dr. Friedberg?
I think the integration is being done, but it's not being done by the right people. Because the family doc out there, the doc in the community is getting all that stuff together, but they're getting it and they're trying to synthesize it. And as I commented before, with the changing technologies that we're all adapting and integrating, the people who are out there in practice are not being trained, not being brought up on it. If they're being educated, they're being educated by more sales reps than medical schools. Don't want to get too political on that one, but the problem is the integration is being done, but we don't have the right people doing the integration, because in order to integrate it, you need to understand all the stuff underneath as well as how it applies to the pointy end of the stick. And that's going to be the problem moving forward for all of us.
I'll just mention something briefly. In the community, the importance of these multidisciplinary conferences is critical for us to interpret the images properly and to understand the context. And I would also say one other thing, which is it's very important for radiologists not to read in a vacuum. So a really good electronic medical record where all of those reports are together. When I read much of the oncologic imaging I read, I really scrub the oncology notes and also the pathology notes and then put that together so it's all context. You add so much more value rather than reading in a vacuum.
And that takes time.
Yes, it
Your
does.
RVUs go down. Great. So let's go on to the next question on the left microphone.
So as somebody who's kind of abandoned pathology for informatics to try to drive much more of the data that we could use into the hands of practicing pathologists, we've started with our very pointy-head informatics societies to start a dialogue between pathology informaticians and radiology informaticians. But that's going to be R&D, and it's going to be a slow build. The question I want to ask the panel is, how do we actually get out into the community pathology and the academic pathology practices across the country and get a partnership going where we actually have a dialogue between pathology and radiology? Because we can talk about these lofty goals of integrated diagnostic imaging centers, but unless we behave appropriately, use our membership societies like the CAP, Dr. Friedberg, how do we actually get something going? We're a dialogue where we are actually providing something that starts kind of the spark that lights a fire for the dialogue between our two specialties to go. It's something I've been struggling with for over 5 years now, and we're nibbling away at it. But to be honest, pathology's too insular, and radiology, which is in a much more privileged position being a digital leader in medicine, seems to ignore the practical nature of the power of our specialties together. So the question is, how do we get the fire lit with our professional societies, with training, and with our vendors perhaps, that when we invest dollars in training, in equipment, in technology, we're nibbling at this issue to pull our disciplines together?
So let's start with Dr. Friedberg, since you're in a hybrid
Yeah,
situation.
I would actually like to ask Jim Brink, who is standing right behind you, and it's chair of the American College of Radiology, perhaps would be most informative answer.
Well, goodness, thank you. I'm not sure I have a great answer for you, but other than to say this is really, I think, a vision we have to pursue collectively. I don't have an immediate plan to tell the audience as to what we would do to bring our specialties together, but it's extremely clear in my mind as well as is yours that this is the future. I will say that I think that we're kind of pushing a little bit at the wrong lever, though, if I may say. Not the wrong lever, but if I may segue on to the comment I was going to make, if I may, and that is that I do think that the main nut here, 95% of the problem relates to just the basic level of practicing subspecialty, at least in radiology, that we may have subspecialty training even within our own disciplines, but our practice models across the country don't leverage them. So until we actually solve that problem, I don't think that actually trying to bring ourselves together will really address it. So I realize I've sort of stolen my place in line relative to the other side of the room, but
I think that maybe Dr. Friedberg could address both your points and questions.
Yeah, I'll make a couple of points. I had 2 years as president of the College of American Pathologists and 2 years before that as president-elect, and I got to spend a lot of time with other societies. I mean, Rich Shulsky and I had lunch a number of times. I actually became a member of ASCO and attended their meetings. And a number of the radiology people, I mean, Jim, you and I have had discussions at various AMA meetings, et cetera, and we're trying to get greater overlap between the societies and having our members attend your meetings kind of things. But on the other hand, I can tell you there are 34 specialties and subsocieties in pathology. And we have how do you be a society of societies is another question, as people often want to get together and talk about the minutia and intricacies of their field, whereas you need to have people who have a bigger picture looking at the bigger part of the equation. I don't know any other way to do this other than just to start doing it by getting overlapping our inherently insular capabilities. The fact that radiologists and pathologists work in the same building but don't often know each other is disturbing. Although we know each other from the tumor boards, we know each other from when we get together and talk about things. But if we didn't, if we started to see ourselves as sort of different ways of looking at the same elephant, so one microscopically up, another one macroscopically down, perhaps, and perhaps there is going to be an overlap in the middle as technology gets it there. But none of us are trained that way, and too many of us end our training in our late 20s and try to just sort of keep that book of knowledge moving forward. And radiology has done a very good job of adapting new technologies, and I am jealous of that because I see pathologists are going to have to do the exact same.
At the risk of overextending my answer, let me just add to that by saying the one domain where I do think where I've seen pathology and radiology start to come together most recently is in artificial intelligence, because the same applications that are being used for automated detection of tumor pathologies in pathologic specimens is the same as being used in radiology. And so for our Center for Data Science at my home institution, we're doing pathology projects right intermingled with radiology projects, and the two disciplines are coming together in that forum.
So I'd like to just extend a little bit onto what Jim just mentioned. Part of the problem we have is that pathology has not gone digital. Once you go digital, there's a lot of stuff you can do with the information. The clinical laboratory went digital 30 years ago. Radiology went digital 20 years ago. Anatomic pathology started going digital really a year ago. And it's going to take a long time for us to make that transition into real digital world, and that's where the AI can really take advantage. In radiology, almost all of your images are acquired digitally. Even in what they call digital pathology, we're still making the tissue block, which is still ending up with paraffin and fixed formalin-embedded tissue that somebody has to slice and make a glass slide out of. And then it's a 20 gigabyte image per slide, and we put out thousands of slides a day. Pathology is going to be digital, and once it becomes digital, like radiology, the overlap will naturally disappear, and AI will be very, very useful there. It's just we're really hampered by the technology that we're still scanning slides back in the days as you guys were when you were taking the film and running it through an image scanner. That's where we're hoping to be soon.
Just answer your question slightly differently. I don't know if you're familiar with NIH has funded 12 centers, physical science into oncology. And the idea of the centers is integrated diagnostics, which include everything. They do have their regular meetings. The problem is that they are heavily, at this point, basic science rather than clinically oriented. But it may be one forum for you to start attending and getting the voice of a clinician into that arena. They actually would like more clinical input, but there are no people that are interested in really collaborating and attending their meetings. I'll be happy to tell you more about. They are very active.
Dr. Cohen,
Yeah, so Mike, let me give you a cynical answer based on my New York upbringing. I think the solution is going to come if the financial incentives are aligned accordingly. Whether that's external from insurance companies, CMS and the like, or internal. I think at the moment, and this has been brought up, we're all so busy. The notion of having to scrub the clinical records instead of having a facile way of getting the clinical information, I think is a huge problem. And so to take anything else on, integrating things becomes an issue. And, implementing this, I think, is a laudable goal, but I think we're going to have to somehow, from a pragmatic standpoint, be financially directed in that way.
Yes, Dr. Stewart.
I just want to make one point about subspecialization to address Dr. Brink's point, which is I'm a big fan of subspecialization. I do think that's the trend, but I think there's a sweet spot for it. Sometimes, even in radiology, I see it. I have a little bit of a hybrid practice. I see both the academic and private practice sides. But sometimes when you have super specialized radiologists, they have their silo, and they're really not comfortable with anything outside their realm. So a good example is a chest CT, which images much of the abdomen. You see a lot of the liver, you see a lot of the kidneys, you see a lot of adrenal glands. And if you have a section that's just chest radiology, they don't feel comfortable looking at those images. And sometimes there's a dedicated abdominal CT, but often not. So if there's a pancreatic mass, whatever, there can be or pancreatic lesion that may be benign or whatever, there may be recommendations for additional imaging, or say a neuroradiologist reads a chest and head and neck CTA and there's a lung nodule at the lung apex. That just may be scarring and a follow-up, not necessarily. So I think subspecialization is critical, but at the same time, you also need to having some general ability, general radiology skills, and to be reasonable is important.
Thank you. Let's go to the right microphone for a question.
Thank you. My name is John Gardner. I got my doctorate over 40 years ago, and I've been called many things, mostly favorable, but mystical, like operations research analyst, statistician, navigational theorist, economist, all kinds of things. But I had the great privilege a year ago of being elected a fellow of the AAAS by the section called Societal Impacts of Science and Technology. And the reason I got up to speak is to encourage awareness, not focus, but awareness of the broader context of societal impacts of science and technology and engineering. And there are what I hear here within what I see as a silo, and you see is a huge family of subsilos, is a problem of not recognizing the broader focus within society, which is not your business to solve. I'm not suggesting that, and I'm not suggesting that you should do anything broader than you are doing, but I suggest that you should be aware of and encourage work in things that are very pertinent to your work, but aren't exactly your work. Let me give you 2 or 3 brief examples, and believe me, there are over 100 like this. Number 1, U.S. Medical system writ large is less effective and much more expensive than that of other G20 countries in the world. That is a problem, and it needs to be addressed. Preventative medicine is an afterthought, as indicated by the full title of what we abbreviate as CDC. And it is not at all clear how much our overall cost-benefit ratio in biomedicine might be improved by a greater focus on preventative work, even if it meant not doing everything we think ought to be done. We're right that more ought to be done in matters of imaging, diagnosis, and clinical practice, particularly in the lesser served communities. All those are all real. There are other big trends that are going on. We're not producing enough medical professionals in every element, and we're not dealing with that question. How do we improve the availability of medical skills? I've been following artificial intelligence for over 40 years, and yes, we're making impressive progress. But I saw the roots of everything that's happening today 40 years ago. We were doing artificial intelligence in pretty much the same manner. What we have now is better technology, better algorithms, and like that. But we're not going to solve our problems with artificial intelligence. It will help, but it'll be just a crutch. The bigger point I'm trying to recognize is we need to expand our use of people, and I think the most unused part of our population, as has been noted in many contexts recently, is women. Women are not being allowed, frankly, to do everything they're capable of doing. And a lot of that is like the Marine Corps didn't think any woman could pass a Marine Corps infantry training program. Well, it's happened. In many other fields, women are doing things that were considered impossible. I think we can expand the use of people. We also have to bring down the costs. We also have to deal with the political issues. My final one will be, not everybody wants the best medical care they can possibly get. I ran into this as a prostate cancer patient, who's thankfully cured now. But my biggest concern was not the cure, but the quality of life. And to what extent should the patient's quality of life be a major factor in the diagnosis and treatment decisions? Just a few of the broader issues.
Thank you, Dr. Gardner. Very interesting comments, and I appreciate the call to ask how this impacts our society at large, which is certainly within the mission of this forum. And to that, I'm going to ask Dr. Brawley this question. So, Dr. Brawley, you have very deftly navigated this position between overdiagnosis and underdiagnosis in our society, and you've had these messages where people should go out and get screening, and yet people should be careful when they go out and get screening, which could be a contradictory message. Let's go ahead and take prostate cancer, as Dr. Gardner had just recommended, and Dr. Gardner, congratulations on your success. Take prostate cancer as a use case. How do we bring these expert diagnosis and whether it be through laboratory testing, without doing a lot of harm? Which and you can, if you want to, briefly mention what has happened over the past decade or so.
Well, in the case of prostate cancer, I think we should have listened to our European colleagues. What happened in the United States in the early 1990s was we started an epidemic of screening and treatment for prostate cancer with the advent of the PSA test, and noted that the prostate-specific antigen test helped us find prostate cancer. We did not go and fully develop that test as a screening test and figure out if that test helped us save lives or prevent deaths. Finding disease is the first in a cavalcade of things that a professional screener looks at, and the biggest important question is, does it help save lives? And so we screened and treated a large number of men in the 1990s, well until about 2010, 2012. Now we understand a great deal more about the pathology, and we're much better able to predict the large proportion of prostate cancers that are not going to progress. And so we've gone from literally in 2004, 2005, a man would be screened today and then told, it's Monday, you need to be treated by the end of the week with surgery, or you need to start radiation therapy. Today, more than half of all men with screen-detected prostate cancer are now being observed, and most of them will never be treated. So we've gotten better. By the way, in Europe, they never really had that screening epidemic. They were much more, I think, appropriate in trying to develop the technologies. And as a result, we write papers now about the more than 1.5 million Americans who were needlessly treated for prostate cancer. They don't have those numbers in Europe in that way.
Great. Thank you. Before we go to the next question.
This was great, but I have to add imaging, because in the UK use of MRI prior to treatment decision is close to 30%. In the United States, it was just published this month, it's 10%. Use of MRI before putting patient on active surveillance is absolutely essential.
Parametric MRI.
Forget it, just MRI. That's the more you know, the simpler your protocol. The less you know, the more you look from 55 sequences on MRI. Sorry, Otis, I can do MRI in 10 minutes and be done. But no, it is very important. And then when you look in that paper, what it is, MRI is heavily used on both coasts, and Texas, sorry to say that, is white. So we have a tremendous variations across our own country in use of tests that really should be done before putting a patient on active surveillance.
So one of the questions, though, would be, are there adequate equipment and reagents?
Okay, so Otis put that, yes. The notion that you have to have 3 Tesla MRI to do prostate is absolutely wrong. 65% of magnets in this country are 1.5 Tesla. It is not the equipment, it's a person that looks at the study. It's the ability, it's the knowledge how to read. Now, there has to be essential protocol, don't get me, and you shouldn't look at the noise. But it isn't, Chris, it isn't 1.5 versus 3 Tesla. 1.5 is a wonderful workhorse.
So can I ask the community members, do you have enough equipment out, especially in Texas, where your vulnerable populations might be?
Well, you know, Texas is a weird place. We don't. I often use the term. It's really the Wild Wild West. We are not a certificate of need state. There is an MRI or a CT freestanding imaging center practically on every corner, along with a 7-Eleven. And so there is a lot of equipment. There is a maldistribution of access to that equipment that comes from the things I alluded to initially, the large uninsured population, and of the plans that the disparity populations can access. Those tend to be the most heavily managed, and the imaging center on their plan may not be anywhere near the geography in which they live. So I can say in Texas, we have enough equipment and good equipment. I dare say that we have good radiologists and pathologists, but we often have a great gap in the ability to access those services.
And did you mention self-referral before? Is that something that deserves more explanation as a true barrier?
I did, and it's a touchy subject, and I'm not going to claim to have a comprehensive or encyclopedic knowledge of all the legal issues. I know that self-referral issues are governed by both federal, state, and local laws. And we in Texas, our Texas legislature has seen it wise that we provide patients with a list of CT services or MRI services or diagnostic lab services when they're ordered. And you have to talk about the alternatives they have. I guess my plea is to consider safety net institutions, the institutions that serve vulnerable populations, and how these self-referral acts may actually be a barrier to timely care. And I use as an example, all the physician and pathology services at Parkland Health Services are provided through a contractual relationship for the professional services to UT Southwestern physicians, including the pathology department. UT has developed a next generation sequencing system that is wonderfully integrated within our clinical record. However, because of some difficulties with self-referral, when we ask the pathology department to help us and guide us on where the sequencing should be used or not, we're met with a barrier where they cannot easily refer to their own lab at UT Southwestern to do it. As a result, we have a very good relationship with Foundation One, who provides those services for free on the patients that are requested, but that report comes back again in a non-integrated way, scanned back in. There is not an integrated interpretation. So what I seek is some better understanding of the safe harbors for those relationships, especially as these molecular and genomic diagnostic techniques, and I think there's analogous things to be said on radiology, as these things become more complicated, I don't know what to order. And it would nearly be kinder in our system if the pathologist could carry the soup to nuts in their expertise, rather than coming back to me and saying, you may need this, that, or the other. I don't know if I've articulated as well as I intended.
You did a fantastic job. Yeah, thank you. Let's go to the left microphone.
Yes, Christian Downs with the Association of Community Cancer Centers. ACCC is going to be launching a educational program on integrating pathology and radiology into the cancer care team, unique to the community setting. And in our initial research phase, one of the things we found very interesting was the lack of communication outside the clinical realm between medical oncology, pathology, and radiology. And it was very interesting. And we were trying to figure out what are some, we understand the digitization problem, some of the electronic medical record problems. Those are long-term issues to deal with. What we want to think about is, are there some things right now that we can do, particularly on the interpersonal communication side, that can get medical oncology talking with with radiology with pathology? And I'm wondering, Dr. Cox, I'll start with you because I know you're going to have a good answer for this. What are some things you could see that you would want to, what kind of interpersonal actions would you want to have with radiology and pathology at the community level? I mean, I know we have tumor boards we could do, but is it going to get a cup of coffee? What are some things that could happen now? And maybe our academic folks could give us some ideas about what they're doing right now to foster that kind of more personal interaction, beyond the electronic medical record and the science piece. So just kind of broad overview.
I don't know that I have any cogent answer to this, other than acting like a very old guy. I remember, and I bet many of my colleagues in the room would recall when I used to make hospital rounds. We'd made hospital rounds twice a day, routinely. You walked through the medical records department, the physician lounge. You nearly always saw and knew the other members of your hospital community. You knew where they lived, you knew who they were, you could recognize them in the hall. This was alluded to earlier, specialization, as well as, I really appreciate what Dr. Cohen mentioned, as well as how we're paid, has put us in many silos. And I admit that I can walk into my hospital and pass people in the hall, the pathologist, the radiologist, and I don't know their name. So I do think there's some socialization we lost that led to better communication. Well, clearly, that world isn't coming back, nor do we want it. We're in a better place in medicine than we were when I started practicing, and I don't want to sound like a Luddite in this, but we need to learn how to what can our technology allow our socialization? I guess one of the things if I had one thing to say, and I think this is what I'm hearing from pathologists and radiologists, and I can certainly say it as a consulting physician, it would be nice if any time a test is asked for or an opinion requested, that a clinical question be clearly defined. It seems like if there was a opening question that's clearly articulated with a name and a beeper number behind it, maybe that would help us move forward.
Great.
I just want to answer your question. Sit down. So in cancer centers, we have now a model what's called distributed radiology. Dana-Farber has it. We have it, where actually a radiologist is a part of the medical oncology clinic. So they are in the clinic where all the, let's say prostate cancer, because we have a prostate cancer center. Our radiologist reading room is right with Howard Shea and all the oncologists, but it's a luxury. And it's a luxury that, going back to Michael, it costs money. Because they are in a clinic, they are asked questions, so therefore they cannot read like an assembly line. They show images to patients, so it costs money. And there are very few centers that can afford that, but it's really wonderful. It's wonderful for patient care because patient can ask. For medical oncologists, it's absolutely superb. And it's actually very good for clinical research because being in the clinic, you understand what are the needs and gaps for the future studies.
Maybe a follow-up with you, just kind of getting an idea of what that looks like so we can show people.
Sure.
Just an idea. Maybe they can
Right. Dana-Farber has it, MD Anderson has it, we have it. That's all I know. I'm sure there are other places.
So I'm not sure there's any secret sauce. I mean, I think one of the unique aspects of the ivory tower, if you will, is the ability to work collaboratively on interesting questions and try to solve them. And I think that by necessity forces working together. You know, in a community setting, obviously, scholarship is not a primary part of the mission. So the best surrogate I can offer you would be ways in which teams could come together to enhance the delivery of excellent patient care. And so in the 2015 report, it talked about how, you know, improving diagnosis is a team sport. So as much as you can bring these people together and to work for the common good of trying to deliver excellent cancer care in this case, the more likely you are to develop those bonds between the people and move forward.
We're actually going to move on to the next question so we can make sure we hear from everyone. I would just comment real quick that it also might be a generational thing that's happening too. Our current workforce is very keen on family time and with the time constraints that we have, a lot of the younger generation just wants to work, collaborate what they can, and then get home and then come back the next day. So there might be a generational thing in this too. Complex. Let's go to the right microphone, please.
I'm Türkan Gardinier with Pragmatica. Let me bring up the issue of colonoscopy. About 7 or 8 years ago, I was one of the early participants at the National Naval Medical Center in actual versus virtual colonoscopy. I went through both procedures, and I'm still on their follow-up list every 6 years to go back. I have gone back, and only virtual colonoscopy was applied. Evidently, the method is reliable, and I'm happy to know that, being a statistician myself. So my question was, are there two procedures, such as colonoscopy, where the same method or approach is being applied or has been applied? And what are the results?
And it looks like Dr. Brawley is going to respond. Can I have you also address how we then democratize that access or get that access out to vulnerable populations?
Right.
Yeah, this is an issue I struggle with. That was the trial that you were in was a New England Journal of Medicine paper, and it compared people who got virtual colonoscopy, right, and those same people got optical colonoscopy, and it found that virtual colonoscopy with the CT was actually a little bit better than optical colonoscopy because the radiologist has, for lack of a better word, the rewind button, right, and can actually go over an area of the colon again, whereas the colonoscopist, in pulling the scope out, is looking for polyps. Right. And if the colonoscopist sees something and says, I just see something, it actually requires a great deal of effort to re-advance the scope again to look in it. So it was a great study. My problem is we spend, $3.3 trillion a year on health care in the United States. It's the most expensive place in the world, and there's a whole bunch of countries in Europe that use $30 a year fecal chemical testing of stool and have lower colon cancer death rates than we do. It's $30 a year for fecal testing of stool. $300 or so for virtual colonoscopy, although that can be done, I guess, every 5 years, and about $3,000 for colonoscopy, which can be done every 10 years. And oh, by the way, my group has published that 40% of Americans over 50 are not getting screened who should be getting screened, and we are losing about 40,000 lives a year in the United States to colon cancer because of that lack of screening. So I'd love to redistribute. If I were czar of the world, I would have fecal blood testing for everybody and very little colonoscopy of either type.
I'd like to address this as well because it is a great test. It's been validated, and it's significantly cheaper. Up to about 30% of colonoscopies don't have lesions that need to be removed, so you can screen quite effectively. I'd also like to make the point that it's non-invasive. There's about a 1% perforation rate with colonoscopy. The biggest barrier, though, is currently Medicare will not pay for it as a primary screening test. It is private insurance will sometimes pay for it as a completion colonoscopy, but it is not approved by Medicare. And the American College of Radiology, we've been working to try to lobby Congress to approve funding for this. Most recently in 2017 went on Capitol Hill. But that's unfortunately the biggest barrier is they won't pay for it. It's a great test. President Obama got a CT colonography rather than an optical colonoscopy when he was president. And that unfortunately is the biggest barrier. So that's where some legislative advocacy would be helpful.
I just add, President Obama got the CT colonography because to put him under anesthesia for a colonoscopy would it have invoked the Transfer of Powers Act, so it was more convenient to him.
But and the other thing is that CT optical colonoscopy, you have to go under anesthesia. It means a day of loss of work. And all those issues, as opposed to a virtual where it's in and out. So there's a lot of significant barriers, and there's a lot of people that don't want to undergo an optical colonoscopy. So it's an access issue.
Thank you. Left microphone.
My name's Rusty Hoffman. I'm an interventional radiologist from Stanford, and what I would be interested in the panelist perspective is how to reduce waste currently in our workup. So we've spent a lot of time, other than the comment on the fecal, so you beat me to the punch, Dr. Brawley. But from your perspectives, both in radiology and pathology, how can we do that? As an interventional radiologist, I see a multitude of ways that patients end up on my table for CT-guided biopsies. I mean, some have been imaged, 10 times before they got a needle from me, and others have been imaged once. And so just what can we do to reduce waste as part of this discussion?
Rusty, I'll just give you, there was a paper in 2001 from Adam Dudley from UCSF, their Center for Outcome Research, that clearly showed if a subspecialty radiologist reads a study or subspecialty gynecologist sees the patient, they considerably less waste because they ask for fewer exams to be sure what's going on, and there is a much faster time to diagnosis. So I'll be happy to give you the paper. It wasn't well read at that time. Sorry, Otis, we probably didn't care about money as much as we do now, but it's really patient share analysis and improvement in both time to diagnosis as well as bottom line. It was Harold Luft and Adam Dudley.
Dr. Stewart?
I think one way that, in terms of patients being imaged 10 times, image sharing is a huge problem. And, particularly when you have freestanding clinics, they get scanned, it's hard to get the CD, that sort of thing. So as I mentioned, some hospitals, you're able to import outside images for comparison, that's critical. But it's really difficult. I mean, there's these CDs, so some HIPAA-compliant server image sharing technology, I think, would help a lot so that you wouldn't have to repeat those scans.
Can I ask, is it a matter of data harmonization, or is it a matter of a financial competition such that there are boundaries?
Yeah, I mean, I think there's an incentive for the host institution to rescan because they get paid for that. So there's that. Unfortunately, there's that incentive. So
as far as sharing the data, is it a data harmonization issue, or is it?
Well, I think I'm not an expert in this part, but I think in part it's a lot of proprietary different EMRs. People don't want to. There's no standard per se, and I think there's huge HIPAA and privacy issues. So I think there's a multitude of challenges.
Is there somebody from New York here, from the state of New York, besides me? We actually are legislated to share data. I just am not an IT expert, so I don't know how it goes, but we were forced to be able to share data. It's a state of New York. Okay, nobody. We will find out the details. Well, New York is ahead again, so.
Yes. Mandated health information exchange.
But
well, yeah, please explain. I just know that we don't have that problem.
And the state's pumped millions and millions of dollars into the HIE and is still giving out now tens of millions of dollars of grants to push data around within the state. But what happens in the trenches for patients in New York is quite different from what happens at our austere academic centers that have this ability but don't proliferate it out to the community. There's a huge last gap. But on the other hand, New York is a leader and actually, as a state, legislating a required HIE. Only 2 other states do that besides New York. And New York was the first. I think Louisiana and Oregon. But this is not my area of expertise, but I think Louisiana and Oregon have taken the same approach.
Let's go over to the right microphone for probably our last question.
Okay, I'm Patty Spears. I'm a patient advocate from UNC Chapel Hill, North Carolina, not New York. I don't think we'll ever have that. So my question is, or comment is really to bring it back to the patient. We talked a lot. I'd like to bring it back to Rich's comment on integration, and it's integration to benefit the patient. I think our workforce is changing, but I think our patients are changing as well as patient care is changing, and a lot of patients are handed decisions to be made, and if they don't have the information that they need, it's really hard for them to make a decision. However, as our technology goes forward, we're also challenged with the technology getting implemented too early, like Otis said, where you get a little bit of overdiagnosis or overconfidence in one number. Just to use the Oncotype DX again, I know a personal friend of mine who just had metastasis of breast cancer after 7 years after an oncotype of 7. So you get overconfident sometimes when you use one number, one value without integrating all the data together. And so I think it's really important also to educate not only the workforce using more practitioners and PAs and nurse practitioners, but also to inform your patients. I think patients don't realize what they're not getting and what they're missing, and so it's really up to us to make sure that everybody is treated the same and equitable, whether they're treated at a cancer center or a community site. So just to keep that in mind as we go forward, to really keep the patient in mind and how we can better serve patients, and patient care and improving patient care is basically the outcome that we need by all of this.
Absolutely. Thank you for your comment. So we are at the end of this session. It sounds like there were 5 themes in our gaps and challenges, which we'll put forward to the rest of the workshop. Number 1 was having adequate skill and judgment, having the right quantity and quality of practitioners. And I think the next session, moderated by Dr. Brink, will be addressing that with workforce training. The second big theme was communication and integration. We heard a lot about that. The third issue was equipment and reagents, but not having equipment and reagents. It's having the health insurance access to those and the financial arrangements of self-referral to that equipment and reagents. The next theme was time, having enough time and attention, which was laced in, I think, a lot of the deficiencies that were brought up. And the last issue was transportation. To see the expert is a challenge. And so that's, to me, is what has bubbled out of this session. And what we'll do now is take a 15-minute break. We'll come back at 10:30 and talk about workforce training.